Dan Curry from Houston, Texas, who is going to introduce what should have been the last talk in the previous session, functional and epilepsy. Dan, take it away. He's going to speak about the status of laser ablation in epilepsy surgery.
Can you guys hear me?
Yes.
All right, great. So thanks, Michael, and sorry for missing my slot this morning. Operating late, sleeping right through my slot. Thanks for the opportunity to talk about laser ablation. It's a big topic. I'm going to go pretty fast on this large topic. Just for disclosures, I am a consultant to both laser companies. I'm asked a lot who the ideal laser patient is in epilepsy, and really it's a lesional epilepsy, deep-seated seizure onset zone. And I immediately think of hypothalamic hamartoma and mesial temporal lobes. Also, keeping in mind it's a small cannula, it's best for multifocal, disparately located seizure onset zones. So tuberous sclerosis complex. My now partnership with Howard Weiner has really brought a lot of patients, and we've really explored the extreme utility in laser ablation in this population, which we'll go over, and also periventricular nodular heterotopia. And lastly, keep in mind, this is a minimally invasive operation. It may be able to capture kids or capture families that didn't want to opt for an open epilepsy surgery due to fear of the operation. So these are the indications I'll mention: hypothalamic hamartoma, tuberous sclerosis, mesial temporal lobes, focal cortical dysplasia, periventricular nodular heterotopias, and I'll talk about reoperation. Obviously, when you're doing minimally invasive epilepsy surgery, it behooves you to get the best physiologic data you can and as much as you can. So I integrate my plans with as many studies as I can possibly get my hands on: MEG studies, PET studies, SPECT studies. And here's some of the examples. We put them all into one stereotactic space to plan. Placing the laser can be done in any way, but I really like using the ROSA and especially incorporating laser ablation with stereo EEG. This is something that's particular to the catheter made by Visualace and Medtronic. It isn't something you can do easily with the Monteris system, but the idea is you use a same bolt for the electrode that you're going to do multiple depth electrode studies to look at an epilepsy network, and then just replace that hot electrode with a laser and ablate that corridor. And we've been doing that here at Texas Children's for quite a while. We use the ROSA, but obviously Renishaw is a great robot to use as well. And then any other time that you're putting in the frame or you're putting in the laser, I really insist on just one thing, that it is framed or rigid stereotaxy and not face localized facial registration, frameless sort of guidance. And it's really best to just do what is the most accurate thing in your hands. I don't really have any great opinion on placement, but you have to be accurate. So rigid stereotaxy is very important. So hypothalamic hamartoma, that seems to be the largest population of patients that laser ablation has improved upon. And it has allowed for an immediate efficacy because it's thermal. It's a very low complication rate for a number of reasons, the least of which is the fact that we're planning with MRIs where we can see the anatomy better than our own eyes under the microscope. And it's a minimal hospitalization. The vast majority of my patients go home the very next day after hypothalamic hamartoma surgery, which is unheard of in the open world. And this is the idea: you put a laser into it, and what this does, the laser delivers the light into a diffuser, and that makes heat. And that heat is observed by a thermogram on the MRI scan. I split the screen to an anatomic scan on the left, thermogram on the right, and a superimposed damage map on that left side anatomy. And I go until my damage map is covered by lesion. And we've looked at our hypothalamic hamartoma series and published it, the last of which has about a 93% rate of seizure freedom, which is very high. I expect that to go down as time goes on. Most importantly, we do have to reoperate. So these are serial sessions. Laser ablation can sometimes limit the thermodynamics can limit your completeness. So sometimes you have to go after up to 25% of the time. Now, we've looked at this data to realize just how much hamartoma do we need to get to cure them. And the number that we came up with, about 66% of most hamartomas, if you ablate them with a laser, will be cured. That lets us know that we don't have to take serious risks on that first ablation uh, session. And if it works, and it should work in the 90% range, then you're fine. If not, then you have to go over the more dangerous bits. The first laser ablation was for tuberous sclerosis, actually many years ago, 10 years ago in August. And this is a cingulate tuber. Since then, we've really expanded the concept, especially with the arrival of Howard Weiner as my boss at Texas Children's, who brings a vast population and great experience of tuberous sclerosis to our center. He was the one that originated the 3 crani idea, where you put in the electrodes, resect the seizure focus, you put the electrodes back, and you find for the secondaries. We now duplicate that in a minimally invasive manner by doing stereo EEGs, doing the ablations, and then putting the electrodes back. So let me go over, just skip through some of the technique for the interest of time. This is the concept that we have. We list all the possible tubers and tuberous sclerosis complex that may be part of it, whether it's by MEG or semiology or EEG or radiologic features. We list them all, and then now we can sample them all with a depth electrode, and then study them, find the source of the seizure, and then bring them back to the operating room. Like, for instance, this kid had a occipital temporal source and also had a frontal opercular source. Again, disparately located seizure sources. We take them back to the operating room, take the electrodes out, replace them with laser fibers, and we ablate them. And here's the diffusion scans and infused T1 scans showing the ablation corridors. Here's the mesiotemporal, here's the frontal operculum, and this kid can go home the next day, as opposed to a 2 lobar resection operation. Here's our experience in temporal lobes. It seems to be comparable to the adult world and the minimally invasive, or the open resection world. This in the adult world has been studied very carefully. This is Bob Gross's work. John Willie wrote this paper, and he found in his first series that he had a 54% Engel 1 classification score. And if he had MTS in that patient, ablating that mesial temporal lobe gets you up to 67%. And as a reminder, the gold standard for open resection mesial temporal lobe epilepsy is 53 or 54% compared to medical management. So we're in the ballpark for laser ablation, and it really can substitute, especially if you're doing a super selective amygdalo-hippocampotomy. Our series in temporal lobe children, we're up to 31. We're doing pretty well. We're 64%. 3 of them needed temporal lobe out, and 1 got an RNS. Also, there's an advantage in minimally invasive surgery, and we may be able to save the networks and increase the memory capacity of these kids postoperatively. Dan Drain's work is something to look into. Does volume matter? It doesn't seem to. In a lot of the big series, as long as you get the head of the hippocampus and half of the amygdala, you're in the efficacy range. If it does matter, though, you can use a larger ablator, such as the Monteris system, or you can use different corridors. This is a 3-corridor temporal lobe ablation that I've done. So in conclusion, I think that mesial temporal lobe epilepsy is a good target, especially if you have MTS, and it can capture those that didn't want to have the open operation. Cortical dysplasia, very common problem in type 1. It's going to be multifocal, like a stereo EEG deal. But in type 2, it's a lesion that you can pretty much entirely encapsulate with a laser. And some of the first work that we did was with cortical dysplasia. We're about 50% efficacy rate. Periventricular nodular heterotopia is another deep lesion. You don't want to injure the white matter on. And so this has been ablated in our series. Obviously, this is a more complicated epilepsy network, needs a stereo EEG, but we're doing fairly well in this rare population that would get whole lobectomies to cure them. Reoperation, you don't have to work through scar when you're reoperating in a laser ablation. So here's a redo hypothalamic hamartoma that was very easily done, no more morbid than the first. And I can touch up hemispherectomies. I've had a series of kids that come to me after open hemispherectomies, a little residual, especially at the frontal basal area. And we can put a laser here and ablate that and stop the seizures without having to open up and risk the hydrocephalus. I've also disconnected. Here's a corpus callosotomy. We've got about 30 of these, and really laser callosotomy has replaced our open callosotomy as a first line operation at our center. here's what it looks like in the final way. Here's a Sega series. I think it's not really an epilepsy operation, but it tends to be a co-traveler. And we've done a number of Sega ablations as well. We've avoided open operation in 3 of them. Problem with Sega, and be very careful about it, is always put a ventricular drain in, because it swells and you can get an acute occlusion of the foramen of Monroe that may be temporary. So in conclusion, I think laser ablation is definitely a first-line treatment for hypothalamic hamartoma if you can do it. It's first line for MTS, mesial temporal lobes. I think it's great for insula. There's a paper out by Dave Clark that you should read that is very, very good on the insula, and avoids all the strokes and when you're trying to battle the arteries. And reoperation is great for a temporal lobe, or for any operation with a laser. It may be a good first line for tuberous sclerosis. We're working that out. We've got about 40 patients under our belt, and we're looking at how we're doing. And cortical dysplasia is, of course, a tip of the iceberg phenomenon. It may be a good first try, but really open resection is probably going to be the need there. And of course, more work needs to be done to work out how we can make these lesions bigger, because we don't know much about the thermodynamics of the brain. We are doing a thermal therapy, and we're only planning anatomically. We need to plan thermally, and that's a whole new science that people have to dig into and resolve. So with that, I leave my email, because I know I went through fast. I'll give this talk to anybody who sends it to me. And I guess there's a question session here.
So Samar Al-Baba asks, he observes an excellent talk. How do you plan to avoid vascular injury to PCA or choroidal vessels during the planning stage for later laser ablation?
So vascular injury and avoidance is very important. Due to the interest of time, I didn't go into the details of planning. The most important aspect of any plan is 1, knowing your accuracy, and 2, knowing what modality you're going to do to construct an avascular corridor as you look as a probe's eye view down each of the corridors that you are going to make. I tend to use an infused T1 that tends to give me the caliber of vessels, the interruption of which will cause a hemorrhage or a stroke. Interestingly, it's really a mechanical worry and a stereotactic worry, not a thermal worry. I have put the laser heat up against arteries and they protect themselves. I've only had 1 aneurysm in my series of over 300 ablations, and that was a mechanical, the larger laser tried to get a corridor in mesial temporal lobe and rubbed up against an artery and caused an aneurysm that ruptured 10 days later. That was the biggest disaster I've had. I now only use the smaller 1.5 millimeter cannulas for long temporal lobe corridors, and that hasn't happened since. You can put heat up against an artery, and the high flow of that artery will protect the artery. We haven't had any trouble, and it's kind of amazing, but we haven't had any trouble. Now, in the old cutting laser era, 70s and 80s, they had tons of vascular problems. So just because it's a laser doesn't mean that you're going to get a vascular problem. The lasers here are really laser thermal coagulators, not cutters.
Question from Rick Boop. Dan, can you speak to laser ablation for periventricular heterotopias? And I'll add on to that my own observation that when you're next to CSF spaces, it can be hard to plan how the thermal effect is going to actually take place. Could you speak to that?
Yeah, that's a great point. Periventricular nodular heterotopia is one of those conditions that looks simple, but really isn't. First, the first consideration is I have done periventricular nodular heterotopia as a laser, very similar to the RF literature on this topic. And it's very challenging to know how much heat to deliver. What the advantage of laser ablation is that we can do it, because it's all MR compatible, we can do it under thermogram, and we can watch the lesion be created, as opposed to an RF world where nothing is MR compatible and you have to go by some dosing, 90 degrees for 60 seconds or something like that. In that pulsatile CSF barrier, you really don't know whether you're going to be ablating blindly. So that's why the thermogram is such a huge advantage here. What I've done on heat sinks is I have aimed and planned for the focus of the heat to go as close to the heat sink as possible, so that the back wall diffusion of that heat center, whether I'm using convection or whether I'm using the actual laser light itself, I don't know yet. It's hard to sort it out in the physics. But the back wall, as it slowly seeps into the tissue, that's what controls the ablation. And you let much of the heat dissipate into the ventricle. Same way you can do it on the cisterns in hypothalamic hamartoma. And sometimes you have to do it at the foramen Monroe in a highly pulsatile child. Now, the thing about periventricular nodular heterotopia, I think physiologically we need to remind ourselves, is that the nodule, even though it's enticing, is probably not always the source. And frequently it's indicative of a migrational disorder, which has caused cortical dysplasia on the cortex above it. And especially if it's in the atrium of the ventricle, you really don't know where that cortical dysplasia is. So it really is a technique where stereo EEG is required to really sort out the network of the epilepsy and then plan what you can ablate safely in that laser technique, with the heat source being close to the heat sink as much as possible. I've got about 7 or 8 in my series. We're writing it up now. It's very complex, and we have to go to RNS a decent number of times too, because we find that we can ablate one side, especially on these conditions that frequently have bilateral occipital problems. You can ablate one side, but you have to RNS the other because you're going to get too many field cuts. But yeah, it's a fascinating, complicated application in periventricular nodular heterotopia, and way better than having to take out the whole occipital lobe in the Milan way to cure these kids.
So thanks, Dan, for that. Alessia Imperato asks the following: when you perform laser therapy combined with SEEG and tuberous sclerosis, you register and then ablate. Do you use intraoperative MRI, or do you first register multiple sites and then implant all the laser fibers you need and then go to the MRI site? Could you describe the workflow perhaps a little?
Sure. So the workflow on tuberous sclerosis is very much dependent upon the physiology. So obviously there's multiple lesions, not all of them the seizure source, and sometimes kids have multiple seizure networks in which you're going to have to address. So we really start with a complex stereo EEG, which is driven by a robotic approach, so it's easy, but the planning is complicated. I make a list of all the tubers that may be implicated in the physiology of the seizure based on semiology and all the other non-invasive tests, MEG scans, SPECT scans, PET scans, BISA analysis, semiological guess on the neurologist, and then looking at some of the problematic tubers that Howard is fond of knowing about, which is going to be the subtly enhancing tuber or the calcified tuber. So we list all that, and we try to make an electrode corridor to sample all of those tubers. Now, I always plan my corridors like an ablation corridor. So as Rick was mentioning, if a tuber is near a heat sink, say the insula, I'll get a little bit closer to the cistern with that corridor, even though I'm sampling. Then we put the kid in the EMU. You know, they'll have 15, so I had it up to 30, 34 stereo EEG electrodes in at times when they're really complex kids. And they'll have a number of seizures, and we'll find the seizure source and define the seizure network based on which of the electrodes is going off first. And then we go back to the operating room, and I take out that hot electrode, which is in the source of the seizure, prep the bolt that I used over and over and over with betadine, and then put a sterile bolt cap and a sterile laser catheter down that corridor. And then I'll transfer from the OR to the MR environment, and I'll ablate that. And then I'll usually take the cannulas out, but in about 20% of them now, we'll go back to the operating room. We'll put all the electrodes back in. And now we'll do like a phase, like a stage 2B phase 2B invasive monitoring. Now we're going to be looking at the electrical behavior of the network after we have ablated what we think to be the driver of the seizure network to see if everything is quiet. And if everything's great, we take everything out after a couple of days. If it's not, I'll go after and get the secondaries in the same manner. I only want to repeat it once. I don't think doing 3 times, I think is crazy. But that's the process. And that is a minimally invasive version of Howard Weiner's brilliant move in tuberous sclerosis 10 years ago, maybe 15 years ago now, where he did the 3 craniotomy technique to increase the efficacies. Obviously, that's a very invasive operation. In Howard's hands, it's safe, but it's a tough operation on a kid. And this is a minimally invasive approach that can have them out the very next day. So I hope that clarifies our workflow on TS.